actually quite warm.
Hi, David.
David, we went all middle name onion.
Oh, yes. Well, I did a WHO meeting and I was Betty Wood. So I had to explain I had no problem with being transgender.
I'm always going to be embarrassed by
No. You dealt with it very discreetly.
something like
So,
David Wood.
What's this?
it wasn't even neutral.
Yeah, I think that will be, you'll probably be able to take it down there unless you want to do it from up here, in which case you can do it on this one. Yeah, I think so, and then you can look at the screen. So
I work from the waters.
so we're already a few minutes over, but that shouldn't matter too much. Thanks, no, you're welcome.
And you,
Great, yeah, that would be lovely actually.
and you live in
Home base is here in Geneva.
Thanks, that's lovely, thanks. So I think we're all set on the panel. Perhaps we need some sound. Can everyone in the room hear me? Great, nodding heads. Has everyone got a glass of wine or water? Or yeah, great, even better. Good evening, everyone. My name's Richard Jones. I'm Partnerships Editor at DevEx, and we're the media platform for the global development community. I'm delighted that DevEx is co-hosting as a media partner this evening's event entitled Global Heart Health and the Road to 2025. And I'm really looking forward to a stimulating hour's discussion ahead. I'd like to welcome everyone here to the Intercontinental Geneva during this World Health Assembly Week, and give a shout out to our online audience as well. So if you're tweeting any comments, hopefully all nice ones, photos or clips from this event, please remember to use hashtag #HeartHealth, that's hashtag #HeartHealth, and hashtag WHA70 for this 70th edition of the World Health Assembly Week. So the long wait is over. We have a new WHO Director General, who I believe is in the building. In fact, he's hosting some drinks in an adjoining room. He had been a staunch advocate of universal health coverage during his election campaign. But what's the state of play of the world's heart health? How will this fit into the new Director General's mandate? And what lies ahead for the reduction of premature mortality due to cardiovascular diseases by 2025? What are some of the major challenges that are going to be faced by us in the room, governments, donors, international organizations, and communities? And what opportunities may present themselves in terms of innovations, in terms of technologies to prevent, manage, and treat diseases in an aging world? There's a lot of big questions to consider here. So without further ado, I'll briefly introduce our panelists and then ask each of them to make their remarks before we move on to questions from you, the audience. So please start thinking about your questions and we'll get to as many as time allows. And so introducing today's panelist, to my right, Bejon Misra is the founder of the Consumer Online Foundation and a governing board member of the International Alliance of Patients Organizations. He launched the Partnership for Safe Medicines India initiative in 2010, and among numerous other awards and accolades, was listed as one of the 100 most impactful healthcare leaders at the World Health and Wellness Congress and Awards 2017. Moving to my right again, Oyeri Onuma is a cardiologist and cardiovascular epidemiologist, currently serving as a medical officer at the World Health Organization. Her work focuses on implementing cardiovascular disease management as a component of the WHO Global Action Plan for the prevention and control of non-communicable diseases.
Thank
Patrice Machaba is Global Head of Development at Novartis Pharmaceuticals. Appointed in May 2014, Patrice leads the global clinical development of the cardiometabolic portfolio. And Patrice joined Novartis South Africa in 2000 as Chief Scientific Officer before moving to Novartis in the United States in 2002. David Allen Wood is Garfield Weston Professor of Cardiovascular Medicine and Honorary Consultant Cardiologist at Imperial College London's National Heart and Lung Institute. He has contributed to international policy and guidelines on cardiovascular disease prevention throughout the World Health Organization and the European Society of Cardiology, and since the beginning of the year has been president of the World Heart Federation. And finally, to my left, Martin Köring is a managing editor at the Economist Intelligence Unit's Thought Leadership Division. He's also global editorial lead for the healthcare sector and has led major research projects on heart health, cancer, chronic diseases, obesity, and diabetes, among many others. Previously, he was Europe editor of the Economist Intelligence Unit's country analysis team, covering politics, economics, and industry trends in Western Europe. Ladies and gentlemen, your panel, round of applause, please. I'd first like to invite Martin to say a few words about a new report and scorecard in heart health. This was created by the Economist Intelligence Unit and entitled Global Heart Health, Evaluating Efforts to Promote Healthy Hearts. Perhaps, Martin, you could give our audience the lowdown on this report and answer questions such as why is it important, what are the key findings, and what should this audience take away with them at the end of this WHO week. Thank you, Martin.
Thanks a lot, Richard. Thanks a lot, everyone, for attending this session. See if I actually need this, but yeah, why not? Being a bit louder, why not? As Richard mentioned, we just released a major new study on global heart health. And it's really exciting because this is really unique. This kind of scorecard, really putting indicators together that assess and evaluate how countries are doing in promoting heart health, hasn't been done before in this kind of depth and in this kind of rigorous method. So just briefly in terms of what I will be talking about, first I will just introduce briefly the scorecard that we produced and that was published last week. 3 key findings from the study, and then 3 key takeaways of cost-effective ways of how policymakers can deal with heart health and how they can promote heart health around the world. And then a couple of more details of where you can find more about the study we just released. So just by way of introduction, as you know, the WHO has the target of reducing, non-communicable diseases and preventing non-communicable diseases by 25% by 2025, and including, of course, cardiovascular diseases. And it's really an important topic because 18 million people die every year from heart diseases. And it's really one of the biggest diseases, killers in Europe, for example. It's the top killer, with 38% of deaths accounted for by cardiovascular diseases. But actually, what is really important is also the economic burden. Lots of countries are suffering more and more because people have multi-morbidities, including several heart diseases at the same time. But the traditional focus on having the focus on reducing mortality is increasingly complemented by the focus on increasing healthy life years, because more and more people live with heart diseases. So it's not just a focus on mortality, but also providing healthy life years for aging populations. And this research program that we did, the Economist Intelligence Unit, was sponsored by Novartis, and it centers on a scorecard that we produced that lists scores for 28 countries and looks at these different elements that make up good policy to promote heart health. and prevent heart diseases and promote better management of heart diseases. And they contain 28 indicators overall. So we invited an advisory panel of experts to help us come up with these indicators. And they are divided in 5 domains. The first one is a strategic plan. So does a country have a strategic plan? How comprehensive is it? Does it have what kind of objectives does it have? Is the scope suitable to really meet its targets? And then looking at public health policies, looking at the biggest risks such as tobacco use, diets, healthy lifestyles, and these kind of things. And then looking at best practice, for example, are national clinical guidelines adhered to in those countries? What about integrated care, multidisciplinary care pathways? Are they in place, and so on? Access and provision, so things like, are the human resources in place to deal with heart diseases? So for example, are there enough cardiologists? What about things like access to innovative therapies? Are there fast track methods in terms of health technology assessment to bring newer innovative treatments into the market? And finally, patient focus, and this is really a core element of most of our research programs. Are the patients involved in their own care? What about e-health, digital health? What about health patient surveys? What about health education? What about patient advocacy groups and these kind of things? And a series of these deliverables that we have produced as part of this program, including, for example, an infographic, a global report, based on the scorecard. We also did an event in Europe. We have an event summary paper on that one, and we have a series of blogs, including by the European Commissioner for Health and the first Vice President of the European Parliament. And also we had several country brochures. So all the 28 countries that we looked at have their own brochure. So if you're interested how your country is doing in terms of heart health, then you can look that up on hearthealth.economist.com. Just by way of example, how one of those scorecards could look like. This is an example of a country brochure for Argentina. So we look, for example, does Argentina have a strategic plan? Yes, it has one, but it's limited in scope, objectives, and implementation. So it doesn't get the highest score for that domain, for example. Then the country has public health campaigns for the most important risk factors, so it gets high scores in that domain. But then if you look at, for example, best practice, there are very few examples in Argentina. Because, for example, they don't really have integrated care pathways. Their monitoring systems for heart diseases are not very good. So that's they get downgraded for that in that domain. And then we have access and provision, things like human resource, clinical guidelines, and so on, cardiac rehabilitation. These things exist, but they're not very good in Argentina, so they get the mediocre score for that, for example. In terms of patient focus, Argentina does promote patient advocacy, but there are some problems, for example, in patient education, health status service, and e-health. So this is just an example. You can look it up for 28 countries from across the world. Obviously, many European countries, but also countries from Africa. We had Nigeria. We had, for example, we had lots of Latin American countries, not just Argentina, but also Mexico, Brazil, and so on. So you can look that up to see how your country performs. The 3 key findings from the overall study from a global level. Of course, I don't really have much time. I'm already running out of time, so we can't really focus on all the key findings. But the 3 key findings from a global level, so very few countries are really looking at integrated care pathways. It's really important to do this, having patient-centered integrated care for heart disease patients, but there's lots of room for improvement in that area. So for example, very few countries have relevant health status surveys, e-health to deliver care, collecting patient data. There's a lot of deficiencies in that area. Only around 1/5 of the countries we looked at, they have monitoring systems such as a registry for heart diseases in place. And for all of the heart disease we looked at, we focus on coronary heart disease, arrhythmias, and heart failure. Inequalities in access to primary and secondary prevention programs is very prominent in most countries. Cardiac interventions are also lacking. So really this integrated care is a big problem. It's not really in place in many countries. Secondly, many countries have strategic plans, including, for example, Argentina that we just looked at as an example. But they're often not very detailed. They're not comprehensive enough. They're not sufficiently comprehensive to really deal with heart diseases. And they also lack implementation. For example, this is an excerpt from our infographic. So 71% of the countries we looked at have developed a strategic plan for heart health, but only 15% actually are fully comprehensive. So they're really could be really effective plans because they are comprehensive enough in terms of objectives and implementation and so on. And 0% of countries, none of the 28 countries, including all the major countries from the developed world, including the US, UK, France, Germany, none of those countries have a disease-specific strategic plan in place, which is a major gap. There are strong public health campaigns and programs running in most of the countries we looked at, and that's crucial for bringing mortality rates further down. However, there's lots of room for improvement in terms of public health campaigns. So, for example, 82% of countries, they have public health campaigns on the most relevant risk factors, for example, tobacco use, healthy lifestyles, and these kind of things. But only 25%, so only a quarter of the countries we looked at, have actually run focused heart health campaigns for one or more of the disease groups we looked at that also look at healthcare professionals and that target specific age groups. So lots of things are good and they're in place, but they're not very specific and they're not really very targeted. So just in terms of three key takeaways for policymakers. So first of all, better provision, access to cardiac rehabilitation programs is really important. So one of the things we looked in the report is what is cost effective, especially in the developed countries. In developing countries, of course, cardiac rehabilitation is difficult because it's not as developed yet. But in most of the developed countries we looked at, cardiac rehabilitation could be cost effective because it prevents secondary cardiac events, it keeps people from ending up in hospital, it keeps patients come back to work. So it has been proven to be a cost effective way in many countries. And it can be adapted as well to a developing country context. Improving patient involvement is really important, especially in self-monitoring of their conditions. That is another cost-effective way of dealing with heart diseases. Employing more mobile and e-health has been shown to be cost-effective. It keeps older and frailer patients out of hospital, for example. And finally, increasing the integration of primary and secondary care in heart health is really important. For example, by establishing networks in cardiac care with a focus really on providing good patient outcomes and improving patient value. This can improve patient care. Such networks already exist, for example, in the Netherlands, and also the UK is starting to develop these kind of cardiac centers. In the Netherlands, there's already an example of having this for Parkinson's disease, so why not for heart diseases? There's also potential there. And hospitals have to move increasingly towards performance-based payments. This is really a core element of value-based healthcare, and it can help also in healthcare, in heart healthcare, if there was more performance-based payment in hospitals. So if you really want to find out more about these exciting new insights from our study, you can go to hearthealth.economist.com, and also we'll be tweeting a lot about this study, and I'm happy to answer any questions you might have. Thank you very much.
Many thanks for that overview, Martin, and I'm sure that our audience will have some follow-up questions shortly. But first, I'd like to turn to David for some input. David, in your experience, what are some of the key factors here that can contribute to a successful national heart health strategy? What's at the core of effective planning?
Well, firstly, I would like to publicly congratulate Dr. Tedros for his election as the new DG. We actually sent a letter of congratulations to him today from the World Heart Federation office. But we have a challenge here because in his 5 priorities, beyond universal health coverage, which we strongly support, he did not list non-communicable diseases, and specifically from our perspective, cardiovascular disease. And I think that does represent a challenge for our community in terms of the prioritization and resources available within WHO for the commonest cause of death and widespread disability worldwide, especially in middle and low-income countries. But to answer your question specifically, I think the answer is firstly a multi-sectoral approach is required at a national level beyond health ministries to include finance, agriculture and other sectors. Secondly, a multidisciplinary approach in clinical practice for secondary and primary prevention. It doesn't really matter how many cardiologists there are in a country. Their preventive care can be provided by many other health professional groups. Thirdly, I think we need to see a strong patient voice and patients taking responsibility for their own care.
And so you mentioned the new Director General of the WHO there. I mean, why should the WHO and other policy makers really prioritize CVDs rather than other disease areas, for instance, cancer or tropical diseases? What would be the core messaging there?
Well, I think because cardiovascular diseases are the commonest cause of premature mortality worldwide and dominate the non-communicable disease agenda, and because we know the causes and therefore how to prevent this disease, to achieve 25 by 25, cardiovascular disease sounds like a goodbye to me. If we're investing not in high technology care, but in secondary and primary prevention.
And so in that sense, what are the key obstacles? I mean, we were talking before the event about issues such as scale and leveraging partnerships and robust financing. What's at the core of moving the needle on progress in CVDs?
So I think the key is really investment, financial investment in prevention services. And that's a conundrum for politicians and policymakers because opening a new hospital and seeing the waiting list drop is easily quantified and within a short period of time, within the political life cycle of the politician concerned. Investing in prevention is a long-term return, although there is plenty of economic data to show that actually such an investment at a society level is cost-saving to that society ultimately. So we have to persuade politicians and policymakers to make that long-term investment.
Thanks, David. And from your perspective, Bejan, what are the factors that you'd like to stress in terms of factors leading to better patient access? What are some of the, again, biggest challenges that block such access, and how can these obstacles be overcome in practical terms?
Thank you, Richard. Firstly, let me congratulate Martin and team. Excellent work. And as patients groups, let me tell you that these work as excellent tools for our advocacy work. When you bring out such reports, it's credible, and we can lean on the data to talk to our policymakers to go ahead to do it. And what I want to tell David is that, David, I went to business school, and the first thing I was taught was your marketing starts or your sales starts when the customer says no. So when the DG has not brought in, our work actually starts. We have to bring it in. And when he has talked about universal health coverage, you see, I look at that slogan as a very holistic kind of a slogan where, all these issues of NCD and all issues concerning access, safety will come in. And I'm sure, he would realize that, he needs to bring all of us into the picture when he talks about the universal health coverage. Having said that, coming from a country, 1.3 billion, which is almost 1/6 of the world's population. And the biggest challenge we have is every year, more than 20 million people are pushed below the poverty line because of the high cost of healthcare. And 80% of the healthcare in India is handled by private sector, where it has to be out of pocket because you're not covered. And only 20% is in the public health system, where the poor can go and access. So our biggest challenge is that how do we identify and bring preventive care right at the primary level so that we can not only reduce mortality, but we are able to save lives. And the cost, almost more than 60% of the patients in India are today either selling their assets or going in a debt to access healthcare. And that's why there's a lot of stress on how do you bring in price controls. the recent, you must have heard how there's been a price control on stents in India. Now, when you bring in price controls, you kill innovation and creativity. And in order to encourage innovation and creativity, you have to bring in the patient's voice. The feedback from patients in terms of the care, in terms of their catastrophes which they go through, their experiences, you have to bring that, and that becomes the focus of any kind of a policy decision. And in my view, it's a great kind of a alliance which has got built today. I really want to congratulate World Health Federation, Novartis, and DEVEX to come together and bring IOPO into the picture. Because it will actually bring in that strength in terms of what we want to do in developing countries or even developed countries, in terms of CVD and how we can, make sure that we are able to reduce the burden and help patients to ensure that they are not overburdened only, economically they are made more free and they have a choice. You see, the best thing about the consumers is what they like most is, you see, when you talk about standards, you talk about choice, you talk about accountability, you talk about transparency, the patients likes that. Those are the most, expected, kind of top expectations of patients. And I always feel that these kind of studies which get revealed and the discourse we have after the study is revealed, and we have so many important people in this room. Thank you for taking time to come and listen to this. It's really nice and encouraging. Because you all are going to be the spokesperson tomorrow when you go back, to the community and talk about it to various people, that what is happening around the world is not fair. We need to be fair. I'll wait for my turn again.
I actually just have, I think it was a comprehensive answer, but I do have one follow-up here, and that's perhaps directly addressed to any of the implementers that may be in the room here. What sort of policies or other factors in your experience have really led to successful outcomes in terms of incentivizing patients to be more involved in their own care? Is it public information messaging? Is it top-down government policy? Or is it a really organic movement? What's the secret?
What has made any of our campaign, like I remember the biggest campaign we did was FCTC. See, when we tried to bring in a regulation on tobacco control. Direct engagement with patients groups or the community is extremely important. And bringing their viewpoint in the forefront. Because most of the time we are never heard. In fact, I feel very delighted that patients groups got invited in this forum, because most of the time people forget. And it's so good a feeling that when we engage with WHO, I remember when FCTC was going on from 2000 to 2004, I practically lived out of Geneva. Because there was such a serious engagement. And as you all know, the first health treaty got signed and ratified by the countries with so much of pressure in terms of derailing the whole initiative. I wouldn't like to speak on who were the people who were trying to derail it, but there was a huge pressure, but it happened and it was successful. Similarly, I would say that, this partnership which has got born today out of this study, and economists, coming in, because we as citizens groups always have an excellent relationship with media and the press. And your report would be a very helpful tool for us. And I feel that, the success would be how you capture the patient's voice and how you capture to ensure that the patients feel that I was taken care at the right time in the right manner. And I was not pushed into a place where I had to create a debt or sell my assets.
Yeah, thank you, Bejon. Oyede, perhaps we could turn to you. And I mean, from a WHO perspective, what is the state of play on heart health Obviously, with the new WHO Director General coming in, we may learn more about this in the coming days, weeks, and months. But are there kind of universal elements within the WHO family in terms of actions that are going to be taken on CVD planning, regardless of country setting? And I'm referring here to the sort of broader sustainable development goals that are universal.
Thank you very much, Richard and Martin. Thank you for your presentation of the report. I think from the WHO perspective, if you look at CVD, it's the #1 killer globally. I think it's a pretty difficult thing for the world's premier health agency to ignore what is the #1 killer globally. So definitely CVD, in concert with other non-communicable diseases, is something that is squarely on the WHO agenda. Our approach to NCDs is and has always been one that is fairly comprehensive. So looking not only at the policy interventions, FCTC, as you mentioned, Bejon, other interventions around salt, sugar sweetened beverages, but also focusing within the health system, which is big focus of this report. And within the health system, I have to say that our particular approach to cardiovascular diseases, and indeed to NCDs in general, is that early detection and treatment is the key here. And it is a key not just for patients in terms of sparing them the morbidity of disease, and as Bejon mentioned, the significant costs of disease, but this is also the appropriate approach for health systems as they think about how to organize care so that you're providing care that is accessible, it's patient-centered, it's equitable, and it can reach most of the population who tend to suffer from CVDs and other NCDs. And how do we think this can be done? We think primary health care is where the bulk of the focus should be, and that is where our work in WHO has been focused on. And incidentally, this focus on early detection and treatment in primary health care actually aligns quite closely to what Dr. Tedros was mentioning yesterday, to say that universal health coverage is the backbone, on which you deliver these services. Now, within that, there still needs to be additional work in defining exactly how it is in primary health care that we can structure these services in a way, again, that optimizes what we do for reducing the morbidity and mortality from cardiovascular disease. The work in cardiovascular risk assessment, management of risk factors at primary healthcare is one of the WHO best buys. We've looked at several interventions in NCDs and identified that as a key one that, when implemented by governments, can give the most return, or a very high return on investments, and again push us all closer to the global action plan goals of 25 by 25, and indeed the SDG 3.4 goals of reducing premature deaths from NCDs by 30% by 2030. If CVD is the biggest contributor to that category, then clearly this is where we need to be putting in our efforts and working in sort of an integrated way across the NCDs. So I'm happy that the report highlighted this, and of course all of this is linked to referral care, but we think that, again, early detection, treatment, bulk investment in primary care, again, against the background of universal health care, is really the way to approach this.
And at risk of perhaps being a little bit speculative, I just wondered what might be on the table for discussion with Dr. Tedros and the other member states within these first 100 days. Are we expecting to see massive changes or more of the same work going forward?
Well, I wish I had a crystal ball here where I could see it and tell you exactly how it would go. But I don't have that. I forgot that today. So we may have to shelve that for the future. But having said that, Richard, I think, again, that in terms of an agenda and in terms of what the WHO does, This is an impossible, thing to ignore. And this is not just coming, as a WHO agenda. This is what we're seeing in countries. This is what we're seeing increasingly, regardless of, income level in countries. So again, based on that, I don't know that it's necessarily WHO's agenda versus what countries are seeing practically on the ground in terms of NCDs and CVD in particular, and how that then drives the overall agenda of what happens at WHO. But I'll bring my crystal ball tomorrow and I can tell you exactly.
Thanks, Oyeri. I guess we'll check in on that next year. Patrice, from a Novartis perspective as a pharmaceutical company, I wanted to ask you, in your view, what's really needed to improve CVD policies and patient outcomes? And as a follow-up, what really is the next frontier for CVD awareness raising, for treatment, and for care? And the big question, I suppose, is how do we get there?
So thank you, Richard, and thank you all for attending. Just by way of reintroduction, I'm not a cardiologist. Sitting next to two cardiologists, and it's good that David and have acknowledged that the patient-centric approach is the right way to go when it comes to CVD. There's a clear understanding also that the scope of the problem in terms of cardiovascular disease is huge. It's huge. There's actually almost a tsunami of cardiovascular disease because of an aging population, and also partly because of the success of statins and preventative care, of smoking cessation, of diet. Now, I started leading the cardiovascular unit because of the importance of heart failure around that innovation. And why I say this is that not too many companies, you're talking about investments, realize that a sustained investment in cardiovascular research and development, including epidemiology, patient care, and the use of new technology, is that important. We've seen an explosion of cancer research and development. And cancer has made huge strides. And it's easy in cancer. They can take genomic samples, they can take samples from patients and map them. And as a result, a lot of the innovation has now moved to cancer. And because they are taking these patient samples and can be specific in terms of how they customize therapies, the size of the innovation required in terms of clinical trials is actually much smaller. The average oncology trial will be 1,000 to 2,000 patients. In cardiovascular disease, because of the scope of the challenge, and because we can't take samples from patients from their hearts, the trials and the investment that has to be done, on average, you'll find 8 to 10,000, 15,000 patients in a trial. And a long studies, and very risky. And when I joined this department, what I realized that even when we are successful in innovating around cardiovascular disease, without an integrated care approach, it is impossible to succeed. The drug is not the only solution. I'll give you some examples. If a patient has heart failure, even in the United States, and they are admitted for acute heart failure, the readmission rate in 1 month is 26%, because these patients are discharged to communities where there is no integrated care. And families have to cope with that. Nurses have to be trained. The use of technology and how do you diagnose patients who are going to be symptomatic. Now, I just came from South Africa myself yesterday, and I'll tell you two personal stories just to show you why I think this is really important. And the reason I was in South Africa is that my twin sister's husband died from heart failure, sudden death. My mother alone also had acute heart failure and was hospitalized for 30 days. So it is important that we work in an integrated care mechanism, that the DG, as everybody has articulated, and as you as policymakers, take this as an opportunity, because without your help to guide policy, to guide guidelines, to guide implementation, it is frantically, to be quite honest, almost the value of innovating around new medicines is not realized by patients because we're not working in an integrated approach. This, I think, is important. I also think it's important that when it comes to policy, that we have guidelines and that outcomes-based reimbursement, outcomes-based healthcare for hospitals is important. I know, for example, in the US, that the 26% readmission rate is something that funders are now targeting to say it is not the right thing to discharge patients into a care system where they are only readmitted back with a risk of 25, 60%. And each time they are readmitted, obviously the risk of dying from infections, which is a new epidemic in the hospital in ICU, increases. So I want to thank you for this opportunity, and I can only make a plea that we need your help for an integrated care approach that makes it patient-centric. And lastly, I'd like to say, coming from a developing country myself, although I work for a global company, the advent of technology is an opportunity to collect data and to leapfrog and allow patients to have access. We have worked collaboratively with several technology companies and governments to generate data. We've had to repopulate heart failure epidemiology and data. In the US, we know 6 million heart failure patients, in Europe 15. But if you ask me what is the global heart failure epidemiology challenge, we don't know. And we need to generate that because it is something that is going to be pretty obvious because of an aging population.
Yeah. Patrice, thanks for your insight and personal testimony as well there. I just wanted to follow up on that issue of aging. In a DevEx preview piece about this event, we heard from the Global Coalition on Aging that because people are living longer, there's almost certainly going to be an increase in the proportion of people affected by CVDs in their lifetimes. How is a company like yours preparing for this now for the future?
So, and thanks for bringing that up. I mean, we know that once we cross the 65-year-old threshold, that the most common reason for admission is heart failure. We know that aging is a risk itself, and we know that although we've managed to succeed in terms of extending patients' lives from primary health care, from prevention, from use of statins and interventional therapy, that their quality of life is not that fantastic. I can tell you that for my own mother's experience, her quality of life is horrible. We know that the mortality associated with that, besides a bad quality of life, is similar to cancer, except bronchial cancer and pancreatic cancer. But I think what is important is that we need your help to make this not only a policy issue, but to come up with guidelines and outcomes-based protocols that we hold people accountable to. Because as I say, the research that is required is a long-term research. I'll give you a personal example of the team that I was leading, and you may know about it. For acute heart failure, we haven't had a new innovation from a drug perspective since digoxin. And when was that? 1776? And the trials that we have to do are long-term, and we fail. So we need your guidance and support at a policy level to make this at a WHO, to say this is a priority and we have partners. And we clearly understand drugs are not the only solution, clearly. And we've learned that. We've clearly learned that you can have an effective drug, but if you don't have an integrated healthcare, you will discharge the patient into a system where you cannot deliver on that promise for the patients. So I think that is important that from your side that you assist and work with us so that we stay the course and address the public health challenges that are the most serious ones. Otherwise, you see a deviation that everybody else is doing research in cancer. Very few people are doing Alzheimer's disease in a significant way. Very few people in the remaining cardiovascular challenges, which is totally inevitable, which is heart failure.
Thanks, Patrice. David, perhaps I could come to you because I believe that you have to shortly leave us to catch a flight. But I did want to get your sort of final thoughts on how to move forward with this issue, how to meet WHO targets, and your key message for the audience in the room today.
So, just very briefly, I think the WHO Global Hearts Initiative, which Oiri can speak to more eloquently than I can, embraces both prevention and control of cardiovascular disease. And we have the irony, or the paradox, I should say, that in high-income countries the burden of risk factors is very high, but case fatality is extremely low because of interventions, angioplasty, stenting, thrombolysis, beta blockade, and all the rest. Whereas in many middle and low-income countries, although the burden of risk factors is lower, case fatality is very much higher. I mean, 8 to 12 to 16 times higher than in high-income countries. So we have to invest in both prevention, but also effective management of patients who develop cardiovascular disease. It's the combination of the two that will have the biggest impact.
And in terms of this investment, just finally, what can be done to encourage non-traditional financiers within this sector to really push forward and to help meet the WHO targets by 2025?
Well, I don't know how governments are going to pay for this, but the thrust of the WHO Global Hearts Initiative is to focus on primary care and to focus on not just the general practitioners, but nurses and other health workers who need to be appropriately trained and audited. But that is where I think the investment needs to be made to have the biggest impact at a population level.
David, thank you very much.
Thank you.
Perhaps turning to you, Martin, and also for Oyere, what's your perspective here in terms of the aging population conundrum and perhaps other fiscal and political challenges? We just talked about financing, but also the issue of rising healthcare costs. What are some of the policy stopgaps that we need to be looking at addressing here? Martin, perhaps I can turn to you first.
Yeah, sure. I think this is really crucial, and from an economic point of view, it's really important to highlight population aging as one of the biggest factors driving higher prevalence, because people are getting older in developing countries as well. I mean, in Europe, we have already seen this, spike in heart disease prevalence and incidence driven by aging. But what about China? What about Brazil? Where population aging, if anything, will only accelerate. And obviously, this has impacts on the fiscal systems already. As more and more people have multi-morbidity, and it's as the other panelists as well mentioned, I mean, this is really an issue that where people survive and actually have multiple heart disease, and not just multiple heart disease, also other conditions, and this multi-morbidity will drive costs up, and that's why it is so important as well to have early detection and monitoring systems in place. And for cancer, there's a lot that heart health can learn from cancer, because they have very effective cancer registries in many countries. And this is really crucial, because if you cannot really ascertain the disease burden, then you cannot really allocate efficient resources to the problem. And that's why monitoring systems, early detection is really important as to deal with population aging and multi-morbidity.
Thanks, Martin. And Oyere, from your perspective at WHO, it's an interesting point Martin raises here about the sort of institutional learning and the way that sectors and even cross-sector actors can learn and work better with each other. What's the sort of movement within WHO going to be in terms of working better together, doing more with less, in order to effectively tackle a disease as large scale as CVDs?
Thank you very much, Richard. I wanted to maybe offer, before I go on to your question, maybe a few points of clarification, which is to say that if you look at the CVD epidemic from a high-income, country setting or low-middle-income country setting, they're slightly different in terms of what the drivers of the epidemic are. I agree that, in the high-income setting where we've worked really hard to try to optimize prevention and risk factors and treatment, you are starting to see significant population aging, heart failure and everything that comes from that. And that is important, and optimizing care in that setting and innovating care is important. In the low and middle income setting, the situation is slightly different. We're still looking at cases where a significant number of people do not have access to basic care. The epidemic increases because the population size is growing, but we still haven't managed to reduce the age standardized rates of CVD. So it means that most people, when they have the first event like David was talking about, won't survive that first event. It's still an epidemic of premature mortality, and one that we need to address by taking care of the basics in terms of educating the population level interventions, treating basic risk factors like hypertension, diabetes, as well as innovating care in terms of referring people early when they have complications and intervening in that way. This is certainly, and we always say this in WHO, but one of those situations where not one size fits all. But there is a common thread in these two sort of situations. One is that care innovation is needed. The second thing is something that you mentioned, Martin, is the recording, the monitoring, the data. In both situations, we do not have the data that helps us understand clearly what is going on and helps us to understand the impact of what it is that we're doing. So as David mentioned, at WHO, especially sort of focusing on this latter part, which is what I talked about, the reducing premature mortality in low and middle income countries, we've recently launched last year this HEARTS package that really looks in a comprehensive way at integrated cardiovascular disease management at the primary health care, be it lifestyle counseling, using clear evidence protocols, ensuring good access to medications as they're needed, bringing in the health workforce. The marker there, as much as I'm a cardiologist and I appreciate seeing the number of cardiologists per 100,000 population, the key number there is more the number of healthcare providers per 100,000 populations. We as cardiologists are not needed to bring about this innovation in care, and then paying really close attention to the way we're doing patient and program monitoring. Let's get the data and use the data to improve what we're doing. And this is a program that we're doing jointly with the World Heart Federation, the World Stroke Organization, CDC, really bringing all partners on board to say, this is important, and the way that we can meet these targets is by all working together in a collaborative way around these targets that we've all agreed on.
And I think everyone on the panel seems to have been in agreement that more needs to be done within and across sectors. What are some of the obstacles here to actually doing that and to collecting the data that we need to move forward on the issue? Martin, do you have any perspective there to add?
In terms of the obstacles, I mean, first of all, as our study actually showed, there seem to be cost-effective ways, but it seems that, as always, governments need to allocate the right resources and also the appropriate resources, because it's not just about how much countries spend, it's also where they spend it. And as many of the other speakers have actually highlighted, some investments, for example, in primary healthcare infrastructure in developing countries could have a huge impact. And also investing in technology early, because we heard as well that leapfrogging technology can be a huge factor. I mean, in many African countries, you don't have sophisticated hospitals, but you have people with mobile phones that can record their health status, which then can feed into a system that can be very sophisticated and can actually help people detect problems with atrial fibrillation or other things that are associated with heart diseases. So it is about how money is spent, and there are some good insights. For example, the finding that cardiac rehabilitation programs can be very cost effective, that are in the report as well, and that policymakers can take away, say that it's not just about how much, it's also how governments invest.
If I just could add that part of the what we've experienced, and obviously we are also keen to ensure that hypertension, diabetes, smoking, diet, etc. is addressed, because that is the best way to, and the most cost-effective way. but there's also a feeling that cardiovascular disease, heart failure, is something that is related to age and is natural. It's not the same thing with cancer. And that's why early detection is important in primary health care and not emphasizing the cardiologists, as you say. Families are important in how they care at the community level. Patients themselves can participate now with new technologies in terms of, am I getting worse? Am I not feeling well? What is the best way for me to access healthcare? That is important. But we need to make this a priority, just like the cancer people made this a priority. And the kind of, the kind of challenge that we face with cardiovascular disease is really monumental. It's millions. We're talking about millions. I can give you figures. For example, in the US alone, there's over 1 million acute heart failure admissions per year related to aging. Same thing with Europe. And Oya is correct. What we see in developing countries, they're even younger age, more economically important to the family in terms of supporting them. But instead of just articulating what the problems are, there are actually opportunities now because of technology. And I think, if you look at penetration of smartphones and technology to collect data and to give you epidemiological data, it's a great opportunity for us. And without that data, you can't make policy. And without that data, you can't say you've improved in terms of the outcomes that you've put in and what is the most cost-effective outcomes. What is clear to me personally, now having worked in this area for 3 years, is that if we don't collect this data and if we don't have an integrated approach, healthcare systems will collapse because patients are living longer. And it will be heart disease, it will be Alzheimer, and cancer because of aging. And patients have to be centric, and I can't emphasize this more than enough. We need your help to articulate this message and come up with the kind of guidelines that we need to drive that kind of care, but that puts the patient at the center and emphasizes primary health care and early detection and treatment where it's appropriate.
And putting patients at the center, we read in the report that in many parts of Asia, for example, funding constraints meant that most patients actually can't afford to access evidence-based treatment. So what are you, Bejan, looking for from an IAPO patient's perspective to really make progress, genuine progress on access to ensure that there are robust policies, but also the funding in place, the awareness raising, the education, this kind of holistic approach to tackle CVDs?
Yeah, David, as I said earlier, apart from making policies very patient-centric, patient-driven, resource mobilization is very important. And that's why we have been all the time speaking to governments like India, which used to have less than 1% of the GDP on healthcare in the public service. We have been demanding for 5% for the last more than 5 years. And I'm very happy to share with you all that in this current budget, the government has raised it double. So it's 2.5 now. But it's still not enough. It's still not enough. And as I said, 80% of healthcare is still taken out of, managed by the private sector, and public healthcare is only accessed by 20%. And that also, the people who really need it, they're not able to get that. So the focus has to be how you make people enablers and empower them. How you make them empowered to access the health care which is meant to be given to them at any point of time. And the only way to do that is to bring in technology. And India is known, for the world in terms of IT. We have all the talents in the country to ensure that more than 100 million people are on smartphone today. You go to the remotest villages of the country, you get an internet connection there. So we need to use technology, and technology has to become the enabler, and then the empowerment. And for all that, I always feel that we can't keep all the time telling the government that you need to use a resource, but it has to be a partnership mode. We are also telling and appealing to the private sector that, look, you are managing 80% of our healthcare in our country. You have to find out ways and means in terms of how do you share your profit for the people who need it the most. And many private sector people in India are doing excellent kind of outreach. Excellent outreach. But it's not well organized in a way that everybody comes together in a partnership mode. CVD needs to get into a partnership mode. There has to be a thrust, and we have to stress the need, that primary healthcare has to be very comprehensive and accessible and be seen that it's actually playing that role which we all want primary healthcare to play, that is early detection. If early detection is taken care, then I think we have made it. We would be able to save not only number of lives, but we will be able to bring a lot of smiling faces in the families, because they're really, really pressurized.
So talking of enabling and empowering, I think at this point it might be good to take some perspectives from you, the audience. I wonder if we have a microphone here. I wonder if we can have a volunteer to hand this around. Perhaps you could just raise your hands if you have a question. Once you have the microphone, thanks very much, Megan. If you could please state your name and organization, that would be useful. We do want to hear your views, but we also want to give our panelists time to actually answer your questions. So please keep any statements or observations brief. Thank you.
Hi,
Just in the front.
my name is Jenny Ward Robinson. I'm from PAHO Foundation, and we focus on public health in the Americas. Thank you for the comments you've made and the challenge in thinking. I want to challenge you even more to think about the fundamental role that public health plays at a very early stage in being an optimum partner in really qualifying quality of life, disease that is organic versus lifestyle, to begin to address the kinds of issues you've talked about, patient empowerment, but also the opportunity to educate, make distinctions, and find ways to then capture information and respond. That's at the patient level. At the country level, it is important for ministries to have data in order to make decisions and investments. Ministers come to their role with big agendas and short time periods. Interruptions come, emergencies come. Trade-offs are win-lose. They're never win-win, particularly in low resource settings. So we're jockeying all the time, and in some places the Minister of Health has the smallest voice. The commitment is to economic development, and the drive is there. So we have a role to play, not just to ask for more investment. We have to also educate why it is important and demonstrate the value proposition that lies within that relationship. And ultimately, if we're able to capture along this a notion of continuum of care, then we can begin to talk about and differentiate where aging becomes a qualifying condition, or where there are contingencies and where interventions can be placed to be effective and to think about targeted and strategic interventions then to promote better health outcomes. Thank you.
No, thanks for that perspective. Perhaps we could take another question and then two questions at the front. Yes.
Charles Kiesley from the World Heart Federation. I was very impressed by the different solutions that the panel presented. And if I just try to summarize, I mean, we're talking aging, it's about our future. And I was wondering to some extent, to which extent we're not looking at the future with solutions of today. And if I would be a bit provocative, in which sector would you invest? And I would say you have the solutions of the technologies, drugs, devices, healthcare workforces, patient education, patient literacy, and you have all the issue of artificial intelligence. We're talking about 2025, 2030, where cars will be driving autonomously, Postmans won't exist. We'll have drones. So in which sector would you invest to solve the burden of the disease? In technologies, healthcare, patients, or artificial intelligence?
Perhaps we could get some answers to this one first. And then
Well, I would always vouch for patients. You have to invest there. But, jokes apart, I would definitely want to see huge investment in primary healthcare.
What?
Primary healthcare. I mean, there's no compromise there. Yeah, and if you look at countries like India, it's absolutely in a very pitiable situation. People have to travel almost 500 kilometers or, almost 1,000 miles to access healthcare, which could have been taken care right there at the doorstep.
oh yeah, do you want to come in on this one?
Yeah, I'll be provocative as well and say all of them. We need to work better and work smarter in the things that we do. Every single area that we've mentioned are all areas that need ongoing innovation. With what we have, with the leaps in technology, we look at every single part of the cascade, all of which are important. It's sort of, a kind of an artificial setup to say which one of these will you do, because in reality, you do need to do every part of that cascade to kind of get to the end point. So I would say, where do you invest? You invest in all. But what do you invest in? You invest in innovating each of those steps to see how we can do this in a simpler, more straightforward way that leans on what we know, leans on the technology that we have, and optimizes what resources we have. And that is all of our challenges. It's not a WHO problem alone, or that of pharma, or that of tech, or the patients. This is the area around which we can all agree and start to think about solutions that can sort of get us to where we need to go. So I can't choose. It's like, having 5 kids, but I think all of them, and let's do our work and do it better and smarter.
And all 5 kids are favorites.
I know, they're all your favorites.
Patrice, where to invest, and then we'll take a question.
It's like a chicken and egg, I guess. Because if I had to say the lowest hanging fruit and opportunity is what has happened with smartphones and technology in the ability to make healthcare democratic. As Dr. Mizra said. And why do I say that? I say that because of smartphone penetration. There's almost, it's limitless what you can collect and do. And collecting data is the basis for policy, is the basis to going and say, yes, we need to allocate resources because this is our burden of disease. So here's something I learned when I joined started leading the cardiovascular team, and I talked about heart failure registries. There is no data in other countries.
Right.
There isn't. And then you start learning that the causes, as Oyere says, are different. But you can collect that now, and we're starting to do that on smartphones with people in rural areas. It's low-hanging fruit. And then I'll give you one last example, because we are also involved in malaria with coactive. And we realize that when the seasons change, if you can't help with access in terms of what is the stock situation at a village level for drugs,
Correct.
you can have the most effective drugs. So for me, it's data, and we have an opportunity. It's not artificial intelligence, but it's people behind, the patients behind the smartphones, yeah.
Thanks, Patrice. Could I take a last question
Sure.
from the front? I know that there's a number of people with their hands up, so perhaps we can go to those with their hands up for a short statement, 30 seconds or less. That would be ideal.
Thank you. I'm Viviana Martinez Bianchi, and I'm here representing WONCA, the World Organizations of Family Physicians. And I had a answer to your question in that investing in a primary care workforce that includes family doctors is a really good return for investment, because you have family physicians who will be taking care of the child, the mom, the grandmother, and the grandfather, and an integrative approach. So you could have in your countries physician-led interdisciplinary teams with people who are working with all the members of the family. My question to the panelists is, why do you think family medicine has been discovered in some ways in more countries. We do represent 150 countries, but we still are seeing that, especially in the developing world, there's still a need for an investment in more of a family medicine workforce, similar to what is happening in Canada, even the US and the UK.
Martin, did you want to come in on the Best Buy's investment question first?
It's a good question, and it's obviously the $100 billion question, but it's also interesting to actually ask how the investment is going to take place, because the where might not necessarily get the right answer, because the where depends on who answers the question. And you will have the stakeholder, each representing their interests, will answer differently depending on their interests. So you have to have a holistic approach. So it's more about how you spend money rather than where you spend money. And one of the ways to do it is actually health technology assessment, like having a proper way of assessing what works and what doesn't work. And that can also work on the primary care level. It's not just hospitals, hospital-based, kind of performance-based payments in hospitals, but you can already also pay family doctors and GPs on the basis of how well they contributed to patient outcomes and how well they contributed to value for patients. So it's really about how you spend money rather than where you spend money. And their data, of course, is important, as we have heard. But also in some of the Latin American countries, what we have now is really emerging systems of health technology assessment. And once you have the systems in place, then it becomes much easier to know how you spend the money. Like Brazil and Mexico are doing well in that regard, and others are learning from that, Colombia and so on. So there are lots of good examples of putting systems in place that can help you to know how to spend money.
Thanks, Martin. Bejan, Oyede, did you want to come in on the question on the front, and then we've got time for some last statements if we could pass the microphone around.
No, I would only say that in India there's a lot of thrust on community, healthcare providers. So there's a huge amount of investment in terms of capacity building and things like that to supplement the deficit which is there in terms of professional healthcare practitioners. So there is a lot of opportunity.
Thanks. Can we have a short statement,
Yes.
please? I believe we've only got 2 minutes left.
I'll be really
so
quick.
Please keep it
Yes,
short.
my name is Ashkan. I am in the public health program at the University of Southern California, Los Angeles. And one of the common themes that I've found, because I've also studied in other countries in Canada and also in Iran, and one of the common themes I've found is that a lot of people do not know about the importance of public health and the importance of public health students in the community. So many undergraduate students do not even know that public health exists. They only know medical student, pharmacy, law, but public health is a degree that is really not well known among people. And I think as a public health student, we can be the voice of policymakers within the community. We can be the tool to promote prevention among people in the community, helping and actually mobilizing other resources. So I just wanted to make that comment.
Thank you. There's a question at the back there, gentlemen.
Thank you. Herbert Ban with Amgen. Thank you for an interesting report and discussion. Just a comment to pick up on something that David Wood mentioned briefly. The report shows that all countries have quite a bit of work to do for different reasons. I would submit that the World Heart Federation's roadmaps on secondary prevention, on hypertension, tobacco, cholesterol, et cetera, could be a useful tool for the countries to assess where they are and how to move forward. And in addition, the Global Hearts Initiative, driven by WHO, CDC, with World Heart Federation support, could also be a very useful program to help the countries move forward. Thank you.
Very good. Thank you. Can I take a last comment?
There was a lady there.
Lady in the back, yeah.
I'm sorry, I'm so short that I'm hidden in the back. This is more of a question. You talked a lot about data quality. Research shows that clinical studies, women are represented only 13% there. So we neglected to talk about this population of women. So how do you correct the data that you're receiving that is inclusive of women, because their signs and symptoms of CVD are different from men? And how do you educate women to recognize these signs? Who needs to be involved, and how do you do this?
Any last comments from the front? Anyone?
Yeah,
There were more hands up before. Someone's put their hand down. But I'd encourage you to keep your questions coming and hopefully continue the conversation after this. There's a question from the lady at the front here. A comment and then a brief response.
I apologize, I grabbed the mic beforehand, but just very quickly, my name is Jason Shellaby from the Novartis Foundation. And just one comment is that, we know the burden on the actual public health system. And I just want to encourage, all of us to think, what other sectors beyond those that are mentioned in digital health, but what does the transport industry have to play in terms of thinking how we move around? What about the food industry? I think there's a whole sort of sectors that we should really bring in, because otherwise we know it's going to be overburdened. In terms of primary prevention, there's a lot to do. And just to echo what the gentleman just said here, I think the country roadmaps from the World Health Federation and the Global Hearts Package are very useful. We see them there. They're present for all countries to use. So.
Thanks. And the lady in the second row.
Thank you. My name is Catherine Hagan with the Global Social Observatory. I like what Bejan was talking about with regard to the mix between public and private. But how are you going to, in fact, engage more effectively the private sector as a crucial part of the process of ensuring that there will be good care for everyone?
Thanks. Thanks for that comment. If you reply briefly.
The only way I say is that the private sector has to think about profit, which is a very sweet word, but not profiteering. So you have to engage in a manner that you know that you're going to give the right dividends to your shareholders, but you don't have to make them very thrilled about your performance by taking away a lot of money from patients. So that's the only way.
Thanks very much, and I'm afraid that our time is up. So once again, thanks to you, the audience, to our panelists, to our co-host IAPO and World Heart Federation, and to Novartis, of course, for supporting this evening's event. A special thanks to Mario Tilio and Megan from the Highlanton Group for their excellent organization in convening such an excellent group of speakers. We'll be continuing our practical World Health Assembly coverage on devex.com, and I look forward to continuing this conversation not only after the event today, but also online using the hashtags Heart Health and WHO70. A big round of applause and have a productive week ahead. Thank you.
I like to be